I'll give you just a bird's eye view of a diastolic heart failure. Now, as you know, about 6 decades back, when many of you were not born, the heart failure were divided into two groups: a forward heart failure, that was not pumping out enough blood for the cells, and then there was a technology known as the backward heart failure. It was ventricle was fails to pump all of its blood because the filling was restricted. So because the filling was restricted, it was not able to put the blood. So that was a backward heart failure. This continued for several years, but with the refinement of techniques and echo, it was found that this was more a diastolic phenomena. Hence, the name was changed to a diastolic heart failure. And from a diastolic heart failure, the current terminology is heart failure with a preserved ejection fraction, because now the heart failure is divided into a reduced, mid-range, and a preserved ejection fraction. So this is, for brevity's sake, we'll continue with the term diastolic heart failure. Now, why is diastolic heart failure important? The incidence is about 40 to 50% of all heart failure patients, especially in Western countries. Almost 5% of the patients in the elderly general population have a diastolic heart failure. Their in-hospital morbidity and hospital readmission rates are almost same as a heart failure with reduced ejection fraction, but unfortunately the treatment is not very satisfactory. So when do we clinically suspect a diastolic heart failure? All vulnerable patients with a dyspnea, either at rest or on exertion or heart failure, must be evaluated for a diastolic dysfunction. So this is mainly a dyspnea, either rest or exertion. So who are the vulnerable patients? The most vulnerable patient, number one is hypertension, number two is hypertension, number three is hypertension, especially with left ventricular hypertrophy. But there are many other causes for this vulnerability of a heart failure with a diastolic heart failure. But this continues to top the list. Now you see, this is patient who was in mid-70s. He mainly complained of dyspnea. He was of hypertension. He complained of dyspnea, and when we did an echo, there was a concentric LVH. This is septum. This is left ventricle. The left atrium was enlarged, and there was a near normal systolic LV function, but dyspnea was the main complaint. And you find, and when we did a Doppler, we'll come to it again later on. The ratio of the E wave to the tissue Doppler E prime was significantly increased, indicative of a very significantly raised filling pressure, because the normal value is usually less than 8. So by the time he could decide his admission, his systolic function normal, he went into pulmonary edema, but was resuscitated. Another patient in the mid-70s, hypertension, mainly complaining of dyspnea. You see this is left ventricle, and you see a concentric LVS present. The left atrium is overloaded, and here you find the same thing. The E oblique E prime is the ratio between the mitral valve early diastolic velocity, which is known as an E velocity, which depends upon LA pressure, and a tissue Doppler early diastolic velocity, which is E prime. So this E oblique E prime is an indicative of an increased filling pressure or increased pulmonary wedge pressure, except in normal individual. So both of these patients had a pure diastolic heart failure, no LV dysfunction. So in hypertension, why? Because in a hypertension, there is a chronic elevated left ventricular afterload. This leads to increased LVH and LV mass. There is a myocyte hypertrophy and collagen deposits. They ultimately leads to a replacement fibrosis, and this fibrosis ultimately leads to a progressive stiffening of the left ventricular myocardium, as a result of which, because the stiffening of the myocardium, the filling of the left ventricle is hampered unless it is hence is known as an LV filling pressure. So the major determinants of a diastolic heart failure are a relaxation abnormality and decreased compliance or an increased stiffness of the ventricle, which indicates a more advanced stage of a diastolic heart failure. And because they determine the LV filling pressures An echo should be able to demonstrate, and it does demonstrate, both these major determinants of a relaxation and compliance abnormality. So the diagnosis of a diastolic heart failure, though invasive studies may be a gold standard, but echo is the most practical modality in daily working conditions, and especially 2D echo, the Doppler, the tissue Doppler, strain imaging and extra. So they are used as a routine in a daily practice rather than invasive study. And these are some of the diagnostic features of a diastolic heart failure: presence of important comorbidities, as we discussed, especially hypertension, heart failure with near normal ejection fraction, a non-enlargement of the left ventricle, and signs of increased LV filling pressure, which is the most important criteria. Other helpful signs may be left ventricular hypertrophy and the left atrial enlargement, which we showed in our patients. So, certain common guidelines for a diagnosis of a diastolic heart failure. One must start with a clinical evaluation, taking a history, finding out what is the any comorbidity, then doing a good echo. A normal echo is very much against the diagnosis of a diastolic heart failure. So we see for a hypertrophy of the left ventricle, we see LA enlargement, we see for a good contractility of the LV, a normal ejection fraction, or a wall motion abnormality. So this gives us a reasonable idea that yes, there is going to be a diastolic heart failure. And these are some of the other four parameters like a mitral Doppler, a tissue Doppler with E oblique E prime ratio, a left atrial volume index, which is a subject because LA is subjected to chronically increased pressure, and a pulmonary hypertension. It is said that in absence of any pulmonary disease, the presence of a pulmonary hypertension, especially in a Western country, is the most common cause is a diastolic heart failure. So these are the parameters we take. And important point is that never rely on a single parameter to be relied for a diagnosis. Always use multiple parameters for evaluation, and that is why multiple algorithms have been developed to aid you in the diagnosis. So one of the good algorithm produced by the Mayo Clinic is that, as you see, we see for four things. We see a tissue velocity, tissue Doppler velocity. The normal or septal region is more than 7. We see for E oblique E prime ratio. We see for TR jet velocity, which should be less than 2.8, and the LA volume index, which should be less than 34. So these are the four parameters we take beside the clinical thing. And the more than 3 are normal, the patient has got a normal feeling pressure. First thing we have to find out what is the feeling pressure, and we must write in our report whether it is a normal feeling pressure or increased feeling pressure. And when more than 3 are abnormal, it is an increased feeling pressure. And both depending on some echo criteria, we can grade also these. And when it is indeterminate, that is 2 are positive, 2 are negative, in those cases, we take other parameters like a pulmonary vein, Valsalva, strain method, and a diastolic exercise, to which we'll come come to it just now also. So this basic chart will tell us whether a diastolic heart failure is present or not, and what is the extent of the failure. But there have been attempts to simplify the diagnosis, make it more clinically oriented, reduce indeterminates, and avoid sophisticated tests. And many of these things have come up. But one common one is what is known as a heart failure with a preserved ejection fraction score, in which these 3, 5, 6 findings are seen, and a point system is given upon the presence of each of these findings. And when this score is more than 6, that means it indicates a preserved diastolic heart failure. What is the advantage of this simple technique is it is a rapid bedside technique using simple, universally available clinical and echo characteristics. It is well validated with invasive studies, enables the robust discrimination of a diastolic heart failure from a non-cardiac cause just by a simple bedside method of things we can diagnose a diastolic heart failure. Then one must mention this PH because LA LA is behind the left ventricle and bears all the strain. So many of these strains of values are very common in the very importantly done in these cases. And we take a LA strain in the reservoir function, and this can also give us a diagnosis of a diastolic heart failure, aid in the diagnosis, and also can help at the grading of the diagnosis. There are different grades of a diastolic dysfunction. As the grade increases, the peak LA strain goes on decreasing, and it has emerged as a very important adjunctive technique for a diagnosis of a diastolic heart failure. So I mentioned few words about diastolic stress echo. In a normal individual, when you stress the patient, the mitral E velocity increases because of an increased blood flow. The tissue Doppler remains the same, so the ratio remains the same. But in the heart failure ejection fraction, this ratio increases. So the need for a stress echo is because it can unmask an increased filling pressure on exercise, because almost 25% of patients show increased filling pressure only on exercise. So resting echo can be very inconclusive, but exercise can be very helpful to mask a diagnosis. And these are the various techniques used for this. And these are some of the indications. But in two conditions, we don't do it: a patient with a normal heart and normal diastolic function, and patients who have already got an abnormal. But mainly a person having a dyspnea at rest, which is not explainable by Doppler, then we do this. So in the end, the various diastolic function parameters, all of them can be looked, whether it is a relaxation abnormality, stiffness, or any of these. They can be easily picked up by various parameters, both by a 2D echo and a tissue Doppler, so that echo plays a significant role. So in summary, a diastolic heart failure continues to be a very peculiar disease, either over or underdiagnosed. Comprehensive echo techniques always aid in diagnosis. Newer techniques are used in special situations, and they are proved to be very beneficial. Increased PA pressure in absence of COPD is an indirect and good criteria for diastolic dysfunction. Post-exercise studies can be very information in a subgroup of patients with dyspnea, and hence it is always better to use various variables and various other techniques so that you don't miss a diagnosis of a diastolic heart failure. Thank you very much for your patient learning.